So last year, or this year actually, right? So for this year, our FQHCs and RHCs were able to start billing for RPM and for RPM. They could already bill for CCM, but bill for RPM. The way that they did this, or that CMS allowed this, was basically just use a G0511, which is the bundled care management code, one time for each of the buckets of care management or RPM service that you use, which paid a lot for 20 minutes of time and for device readings. But one was kind of hard to, it wasn't easily trackable by CMS to know what the FQHC was doing. It was difficult from a standpoint of how this should sort of be done on the FQHC side. Do you do it for every RPM service? Just for the first RPM service? If you do devices and then 20 minutes, is that 2? But then if you do another 20 minutes in RPM, is that 3? What about just initiation? Is that a whole G0511? It was a lot, right? It was sort of a very unspecific way to go about implementing these things. And the reason for that is kind of the whole underlying billing model of FQHCs is supposed to be bundled payments. So every time the CMS is unbundling something, and it's not all inclusive, they do it with more reluctance than is probably reasonable, because the kind of the idea of it is to have all-in-one payment, bundled payments. Well, it sounds like the implementation of this, or at least the initial like G0511 billing side of things, has made CMS sort of realize that, okay, we're not going to bundle it, and they broke it up for next year. So basically, it used to be that, or this year, not used to be, this year, currently this year, and they're giving a 6-month window into next year. If you want to take it, you can bill for the G0511 for the base monthly RPM, and then another G0511 for 20 minutes. So with 20 minutes of time, you're getting paid, let's say, about $146, dollars. Great. But if you do 30 minutes or 40 minutes or 50 minutes or 60 minutes, doesn't matter. That's what you get. You get 146, right? So the floor is pretty great, but the ceiling is super restrictive. Or I guess the ceiling is super low. The floor and the ceiling are very close to each other, right? So the change means that the FQHCs and RHCs are going to be billing in the same methodology that general clinics are going to. This will be the one area where they are not special in sort of the billing area as far as how they can build these things out. So if you look at this, for the same 20 minutes in device, you're getting paid a little bit, not even a little bit, you're getting paid a non-insignificant amount less. But you get paid more past that for each 20 minutes that you spend. You get paid for the initial enrollment separately. You get paid for if you spend time on CCM and time on RPM, and you fill out both buckets. It is a lot more flexible. And in our experience, because we have quite a few FQHC customers, the 20 minutes for the sort of patient population that RHCs have, it was rarely 20 minutes. We were spending, there's a lot of folks that, especially sort of rural, more indigent areas, where a lot of our customers and our own care team were spending a lot of time. We can't really cut them off because it's some, it's care that they need, but at the same time, you're not getting paid past 20 minutes. So although you get paid less for the initial amount, I do feel like this is probably a good change. I think that from the revenue side, it's going to even out and have a better upside for patients who really, really need it. If you do this with APCM, suddenly there's more revenue to be made, most likely, especially given how many qualified Medicare beneficiaries there are for a lot of FQHCs and RHCs. So I think this is a good call generally. It also just gives better incentive, sort of matched incentives to making sure that there is care management where it's needed versus, you doing just one device in exactly 20 minutes, or even just doing a device and just doing the 16 reads with no care management. So a change, it's going to take a little bit of adjustment, but I don't think it's necessarily a bad change all in all.